Perfect. Hello, Edgardo. How are you?
Hello, everybody.
Hello.
How are you?
Fine.
Good morning, everyone. I am going to start a surgery right now. I will be watching you. God bless you all, guys. Thank you.
Hello,
Okay.
Edgardo.
Marcelo.
Edgardo, shall we start?
Perfect. I think, Mariano, welcome to this IPSOLAC webinar, migration of sleeve gastrectomy. We have very good surgeon and friend today, expert in sleeve gastrectomy and in this topic. And for start, I want to invite to our IPSOLAC boss, Lucio Poggi. Please, the panel is for you.
Okay, thank you very much, Edgardo. Good morning, good afternoon, good evening, all of you. And it's a pleasure to me to participate in this, my first international webinar as a president of IPSOLAC. And I welcome all of you to participate in this webinar that is prepared for try to talk about something about gastric sleeve migration, that it is a real problem with the sleeve gastrectomy that we need to fix, and we need to know what happened and what I'm going to do in the moment of the severe symptoms, or in the moment that there's no symptoms, which is the problem, and how to manage. These all these things are going to touch our speakers, and I only want to pass the microphone to Edgardo and Mariano Palermo, our members of our communication committee, for start officially this webinar. Edgardo, Mariano, please begin. Please.
Thank you so much, Lucho. It's an honor for us, for Edgardo and me, to be part of this trip that is starting. And today we have two talks. The first talk is going to be given by Luciano Poggi. It's going to give the talk about diagnosis and impact of the sleeve migration. Then Andres Hanssen is going to talk about prevention and treatment, and also have a panel of experts to discuss all these topics. Marcelo Loureiro from Curitiba, Patrick Noël from France or Dubai, and then David Noca from France. So, Lucho, next minutes, Luchito, not Lucho. All yours.
Yeah. Good morning, everybody. Can you please allow me to share my screen? Because that feature is disabled right now. Let me see. Still disabled. Can the host please allow me to share my? Okay, it's.
Yes, you can share.
No, it says host disabled, participant screen sharing. Not yet.
Technology is good, but sometimes
Try now.
Here we go. Okay.
Okay.
I got it.
Yes.
All right. See the right slide? Yes. Okay, so again, thank you for the invitation. This is a very challenging topic that I'm going to try to answer some questions about it, because I think we have more questions than answers regarding this topic. All right, here we go. So the sleeve gastrectomy, we all know, is the most common bariatric procedure. And interesting enough, the GERD has been, for some authors, been called one of the Achilles heel of the gastric sleeve. Some other argues actually that it's weight regain, but that's another debate. What we know is that changing the stomach anatomy could predispose to sleeve or stomach that will migrate and also cause de novo GERD, and that's probably the main concern of this. what is the migration of the gastric sleeve? Basically, is the migration of the GE junction into the mediastinum. And a hiatal hernia is no other thing that basically this migration in this type of patients. I don't think we can actually differentiate what it would be a paraesophageal hernia when you have a gastric sleeve, right? You, in theory, have no fundus. So whenever a migration is going to occur, it's going to be a sliding type of hernia. How often does this occur? Probably 5 to 50%, probably underreported. And most studies actually have found that this finding occurs weeks, even months after surgery or years after surgery. However, acute sleeve migration has also been reported, and this is something very interesting and that might require an acute intervention as well. So whenever we look at studies and we see this study where they follow up patients with upper endoscopy, they excluded patients that had hiatal hernia repair, and they excluded patients that had intraoperative hiatal hernia as well. They found only a 7% of patients with intrathoracic sleeve migration. Interesting enough, they had a 30% of patients that had suspected hiatal hernia in endoscopy. However, this was not confirmed during surgery. So this just catches my attention in terms of how do we diagnose, and surgically speaking, how do we explore the hiatus? Were there maybe more hernias? We don't know. So these patients usually, when they have a migration of the sleeve, can present with different type of symptoms. Most of the times, it's going to be like GERD related. In the cohort in a cohort of patients, they found that a high percentage of patients will have symptoms related, such as heartburn, nausea, vomiting, epigastric pain. Some might be asymptomatic, and that's probably the most important question. I mean, how often or how many patients are just walking around having some mild reflux, and we will tell the patients, well, you might be eating too fast, maybe you don't need an endoscopy, maybe you don't need to come to clinic. If the symptoms get worse, maybe come back. So the follow-up is always challenging in these questions, and especially having a routine post-op follow-up with imaging is also another challenge that I think we all encounter every day. What about the presentation? Again, in terms of the diagnosis, some patients can present acutely and some others, or most of them, in a chronic fashion. In terms of acute presentations, most of the patients could have maybe gastric obstruction or esophageal obstructions. So basically obstructive symptoms, and this might, in this early stage, warrant some type of intervention. In terms of chronic presentations, this is where we find these small hiatal hernias, some other large, some others with gastric or esophageal dilatation. That makes me think, I mean, when did this happen? Even in the acute presentations, you can see this gigantic esophageal dilatation. It's not common that a patient 2 or 3 days could have an esophagus this dilated. So was this missed during the first surgery? Is there like an esophageal dysmotility problem here? Those are questions that are very difficult to answer. No, this is a case presented by Dr. Pavelko of an acute migration that really catches my attention. I mean, this patient was not supposed to have a hiatal hernia prior to surgery, had a BMI of 38, so no really severe obesity. However, the patient had really mild GERD with no esophagitis. And actually an upper GI preoperatively was done and reported as normal. In this video, you can see this important hiatal hernia, and it would seem that there was a part of the fundus that was missed in the first surgery that actually the surgeon decided to resect again during this acute presentation. During the follow-up, these patients had the symptoms resolved, but again, when did that occur? Some interesting things to know and see on these patients are the medical problems that this patient had, such as lupus or a kidney transplant. And that's going to be important in terms of why does this occur? Why do our patients get a migration? So some authors have tried various attempts to explain the etiology of this complication. So some of the theories could be weight regain, right? Increase intra-abdominal pressure, poor weight loss, older age, maybe pregnancy, all in the same direction, previous hiatal hernia repair, maybe malnutrition, intractable vomiting. That's probably one of the most common things that most of the authors point in terms of acute intrathoracic sleeve migration, right? So if the patient is vomiting, whenever we vomit, we know that in normal anatomy, the GE junction will go up, will open up, so we can be allowed to vomit. So intractable vomiting could be probably one of the reasons why the hiatus opens up, and why do we get these hiatal hernias where previously there was really nothing. Other diseases, again, the case presented was a patient that was probably under some immunosuppression medication that also has lupus. And some authors even advocate that maybe laparoscopy, that doesn't create a lot of adhesions, could be a reason why the stomach easily can migrate upwards. Some surgery related, and these are probably the most concerning ones, extensive mobilization of the stomach with resultant of loss of the anatomical attachment, the normal attachments of the stomach, removal of the fundus. Again, this is a narrow tube that can be easily pulled up by the esophagus, a high pressure system that will create pressure, I guess, upward. The innervation of the G junction, I'm not really sure about that. Vagal nerve injury, maybe. Esophageal kinking at the time if we repair the same time a hiatal hernia. Other important theories are intraoperative iatrogenically induced weakness of the hiatus, or are we making the hiatus weaker after our dissection in order to explore it? Should we explore every hiatus? I don't think we have an answer for that question. Again, this is all a game of pressures, right? So if the patient has the fundus removed, if the patient is going to have a narrow tube, in normal anatomy, we're going to see that the stomach has a low gastric pressure, but there is a positive intra-abdominal pressure, a negative intrathoracic pressure, and whenever we disrupt, we know all the different fibers or component of the anti-reflux mechanism, then we're going to have a weaker area in this zone that it should actually prevent in a normal setting the reflux. And that's what actually we see in manometry, where you can actually in this diagram see that the area in blue is a high pressure area. This is in normal anatomy, where the sphincter plus the right cross and the fundus will basically make all these fibers collapse and create an anti-reflux mechanism. Whenever this migrates and get basically a split in two by the diaphragm, you're going to see that these forces are divided. So you don't have this one large force like in this figure here on the upper right side of the screen. And you're going to have these two weak pressure zones that will not be able to basically prevent the reflux. And that's probably what we're going to see with this migration. Again, imaging studies, what to do. Usually endoscopy is the most common one that we perform. You can see this endoscopy. This is one of our patients with hiatal hernia and severe esophagitis that previously didn't have these findings. And the endoscopic reports point out that patients can have even non-erosive esophagitis, and probably the most concerning one in the last probably 5 to 10 years is Barrett's esophagus. It's very important whenever we do an endoscopy, when the sleeve is dilated, you can probably do a retroflexion and look up to the G junction and actually see how that area is working, and actually have an idea if there's a hiatal hernia. So the main problem with endoscopy is that it, of course, depends a lot on the one that is performing it. So that's why we usually advocate that it's ideal that the surgeon performs the endoscopy pre and post-op. In terms of sensitivity, we know that endoscopic findings are usually the most common findings reported in the literature. However, we also know that manometry can be more sensitive. In these studies, for example, you can see that sensitivity of endoscopy for hiatal hernia is not as high as manometry. Of course, manometry, we're going to talk about that in a little bit, but it's another type of test and can be sometimes troublesome. Upper GI X-ray, this is probably the most common, the second most common test performed whenever patients have symptoms, and usually not performed as routine during follow-up, has a really, really low sensitivity for leaks. And unfortunately, that's what we've been focusing in And actually, this has been demonstrated in several studies. Upper GI or routine upper GI has no role in terms of diagnosing leaks. However, it might have a role obtaining a baseline of our anatomy, especially in these really acute hiatal hernias, or especially understanding, I mean, how is the esophagus and the stomach going to work now that you don't have a fundus and you change the anatomy? It's a study that is really not really that doesn't have a high cost, at least at our institution that we've been trying to performing this routinely. It costs around $70 compared with a CT scan that costs $250. But that depends again in terms of each institution what you're going to choose to do with your patient. So I think it's out of question. The upper GI doesn't help you in terms of diagnosing a leak, but it might help you to have a baseline. And this is one of our patients that had no GERD symptoms, had insulin resistant, a BMI of 35. We did an upper GI. Initially, there was no hiatal hernia. You can actually see this from my perspective, beautiful anatomy. However, it catches our attention that this esophagus is not normal. It's a little bit dilated, and actually the radiologist didn't report that. However, when the radiologist put the patient with us on supine position, we were able to see this black area here that is some reflux. The endoscopy was not normal, has a very, very mild esophagitis with a normal GE junction. So this patient was consulted actually to have further workup, but the patient did not want that, and the patient only wanted a gastric sleeve. So how to proceed with this type of patients? Well, what we did was to do a sleeve gastrectomy, and 7 months after, the patient complained of mild GERD symptoms. And this is probably a very common patient for all of us. The patient is very happy with the results, lost some weight, doesn't have really severe GERD symptoms, are very mild, very occasional. And what we see in endoscopy is this: the fundus migrated, or not the fundus, the GE junction migrated, got a little bit dilated. And actually, if you pay attention closely, you can actually see some clips that we initially left there routinely to mark the top line of the stapler line. And that helped us to really figure out that there is, of course, this is pretty obvious, but there is a migration of the sleeve gastrectomy. 3D CT scan is a very important test also to perform, probably has gained some popularity in the last couple of years due to its high sensitivity to diagnose intrathoracic sleeve migration. And actually what we can see is the stapler line above the diaphragm here pretty clear in this study, even without the 3D reconstruction. But the 3D reconstruction has also several other benefits that can help us to identify if there's a kinking or a twist or any other problem. This is a study that we presented back in 2019 at Obesity Week, where we performed upper GI and CT scan on 113 patients pre and post-op. And what we found was 76.7% had symptomatic GERD, and actually 62.8% of those had a migrated sleeve. Upper GI contrast study was positive for migrated sleeve only in 51 patients. So there were actually 20 more patients, or 39% more patients compared with upper GI. And this is important because whenever you have a migrated sleeve and the patient has symptoms, I think is a very important component to determine that this patient will require surgery at some point probably, and a pill or a medication will not make the job to take care of a mechanical problem. So again, the 3D CT scan help us to determine how long is the hiatal hernia, how large, what's the separation between the diaphragm, what's the anatomy of the gastric sleeve, in terms of evaluating other options. What is a very important topic that nobody talked about in terms of 3D CT scan is that there is not a standardized protocol. Some of the studies actually report using oral contrast, even in 2 portions of half a liter. I don't remember if one of my patients can drink half a liter of fluid with contrast, and even using an antispasmodic medication to allow the stomach to dilate. What we've been using, actually, this protocol started back in 2008. We've been using effervescent sodium bicarbonate that the patient will basically swallow, and will allow us to see how the stomach get distended. and we will allow us to do all this reconstruction. But this is what we have been using. I know that Dr. Hanssen is pretty familiar with these techniques. I'm pretty sure he uses also sodium bicarbonate. He's probably going to tell us a little bit more about it. Last study, but not least, esophageal manometry. Esophageal manometry has shown to be more sensitive and specific than esophagogram and an upper endoscopy. This is a study done in a normal population, where actually the sensitivity was on 94.3% and a specificity of 91.5% in terms of diagnosing sliding hiatal hernias. This is one of our patients where you can see actually a normal manometry before sleeve gastrectomy, where you can see there is a really clear transition of the esophageal bolus or the fluid going through the esophagus. This upper line here is the upper upper esophageal sphincter or the lower esophageal sphincter, and here we have the diaphragm. And here in this manometry after the sleeve gastrectomy, what you can see is there is an interruption of the bolus. There is a lack of pressure. These colors, yellow, red, talk about pressure. So this esophagus is not working, and actually there is a separation between the components of the GE junction in the diaphragm, causing basically reflux. And actually you can see here in a previous episode, when sometimes we ask the patients to breathe, take a big deep breath, you can see actually this red area of high pressure shows that there is something coming up from the stomach, only breathing. So that's a very important thing to know and understand. There are several maneuvers that you can do with manometry also to understand if the patient has reflux or not, such as having the patient in supine position or up will make difference in terms of how sensitive can a manometry test be. This study, only in obese population, they considered the gold standard surgery to diagnose if there was or not a hiatal hernia, and actually they were able to find more hiatal hernias with manometry than with upper GI. This is a very small size of population of patients, but still tell us a lot of many important details regarding the manometry. This is one of our studies where we actually look into patients awaiting bariatric surgery. And this is very important because this is the moment where we can actually diagnose an esophageal problem. Patients have obese patients have a prevalence of 22.6% of dysmotility. In the literature, this ranges up to 50%. But most importantly, that after surgery, we can see more dysmotility. But the other thing that we can see that sometimes is not really discussed is that when you do a pH study, and this would be another talk about esophageal motility and physiology, is that you can see how the impedance number increases. So sometimes the patients might not have reflux symptoms, but still having reflux, might not have a positive Demister score, but they will have some reflux that might not be acid going up the esophagus. Just one couple more of slides. What is the impact of the sleeve migration? This is where we need to balance symptoms and anatomical findings, because we know that sometimes we're going to have patients with severe esophagitis that might have very mild symptoms or no symptoms that are actually happy with their results. And that's kind of interesting. So in this study, again, where they diagnosed migration with CT scan, they found that most of the patients with migrations, 100 patients, 30 migrations, the patients with intrathoracic sleeve migration had a higher BMI, had more total weight loss. However, they had more number of patients with suboptimal weight loss. Basically, patients that didn't do that well with the sleeve. But also they did a questionnaire regarding GERD symptoms, and they found that the patient had more heartburn, more regurgitation, and more vomiting compared with the ones that didn't have these findings. So this is a very interesting, again, study. And I already presented this study that basically told us that there was a group of patients with small hiatal hernia diagnosed in upper endoscopy that was not verified or confirmed during surgery. But what we can see is that after surgery, even if this is almost 100 patients, we have more esophagitis of any kind, pretty much Barrett's was not present. But what we have is more symptoms. So basically having intrathoracic sleeve migration means having worsening GERD and more symptoms and also more anatomical findings. What are the indications of conversion? This is probably gonna be discussed a bit more by Dr. Hanssen. But what we know is that patients, depending on the cohort of study that you will look up, GERD is usually the first or the second reason why patients will get a revision or a conversion, actually. Talking about basically 30% of patients having GERD, 40% of patients having GERD, and for some studies, actually 52% is actually insufficient weight loss. One of the last studies I'm going to present in terms of when you see these huge systematic reviews of 10,000 patients, what you're going to find is that hiatal hernia was only found in 41% of patients, but only in 6 studies. So are we missing more hernias here? And the main problem with these studies is actually the heterogeneity of the studies and how do we diagnose this hiatal hernia, because several of these studies did not have pH studies or impedance or manometry or even 3D CT scan that nowadays is so popular. So again, the revision was only 4%. This made me think maybe we're not doing that bad with the sleeve. Maybe we're not going to be revising as many, but again, the heterogeneity of the studies is something that really catches my attention in terms of what is really the incidence of the migration. And here, trying to be a devil's advocate, I just had a thought regarding how common hiatal hernias are in the obese population, 10–40%. How common are hiatal hernias in patients that are above 55 without any surgery? Probably close to 50% according to some records, but most of the patients are not symptomatic. Whenever we do a hiatal hernia repair, you have a 1 to 7%, up to 18% chances of having this hernia recurred. Of course, it depends on the hernia size. The sleeve gastrectomy has a hiatal hernia report that goes from 5 to 50, but the bypass also has this problem, 10.8%. Most of the studies report that are less symptomatic, less anatomical findings. Of course, this is not a high pressure. What about OAGB? This has not been assessed by any study. However, they talk about some 29.3% associated with hiatal hernia. And lab band, interesting enough, has a very, very low rate of hiatal hernias. Conclusions, I think gastric sleeve seems to have a high incidence of intrathoracic migration. The diagnosis has multiple options. I think every test has some advantages. Those should be actually features that are complementary in between. The 3D CT scan is one of the best tests for diagnosis. Sleeve migration represents an important pathogenic factor in the development of worsening or postoperative GERD and eventually surgical revision. So I think that's where our focus should be. Future directions, I think thorough preoperative and postoperative workups should be considered to have a better selection of patients and a better post-op diagnosis of intrathoracic sleeve migration and GERD. Thank you.
Thank you, Luciano. Amazing talk. I am very happy to invite all of you. This panel is amazing. I thank you, Luciano, for this talk. I think you could continue with Andres. Andres have a big experience in this topic too. Andres Hanssen is working in Colombia, and please, Andres, he will talk about prevention and treatment of migration.
Hi, everyone. Good morning, good afternoon, good evening. I'm so privileged to be able to be allowed to present today. I'm hopefully sharing my screen already. Just a minute. Okay. Some of the aspects I'm going to consider to speak about today has been already addressed by Luciano. But it's very interesting that, as you probably know, revisional surgery rates has been increasing over time. And today, the rate of revisional surgery has almost reached the numbers that primary bypasses, which are performed today. And many of these revisions are performed in patients that had previous sleeve gastrectomy, as you probably know. Several very recent publications has addressed the problem of intrathoracic sleeve migration and considers that this phenomenon is probably more frequent than we are used to think, and probably is underreported. As Luciano has already said, the main features of this problem are severe GERD, probably epigastric pain. Some patients also refer dysphagia. And also, Luciano reported that one of the most frequently performed studies for addressing this problem is the CT scan with 3D reconstruction. And in the series presented by Dr. Saber is probably the most frequently performed study. But which are the characteristics of the patients, or perhaps some risk factors that those patients with sleeve migration may have? And Dr. Saber reported that the obesity type has some impact in the risk of developing intrathoracic sleeve migration. And central obesity has a little, has more risk. Over 94.7% of patients with sleeve migration have central obesity. The previous hiatal hernia repair or existence at the original operation is also a factor that is frequently found in those patients with sleeve migration. This is sort of a very recent publication from people from the Middle East, and they propose surgical an algorithm for managing intrathoracic sleeve migration. Also, in their publication, severe GERD is one of the main symptoms or problems associated to sleeve migration. Interestingly, they perform one anastomosis gastric bypass in some of these patients, because as you can see here, Roux-en-Y gastric bypass plus repair of the hiatal hernia is the mainly performed procedure for correcting this problem once it is diagnosed. As Luciano also said, we have been working in volumetries and 3D reconstructed images since a while. In fact, we have published a couple of articles on the topic, and we have found that this kind of technology is very useful, not only for diagnosing the migration or the extent of the hiatal hernia, and also for showing some other problems as twistings or strictures or some other features of the sleeve. Most of the papers highlight that the intrathoracic sleeve migration occurs in 5 to 10% of patients undergoing sleeve gastrectomies, but we have found that even small defects are found in the over 40% of patients that had a previous sleeve gastrectomy. The most common symptoms are reflux, nausea, and vomiting, and epigastric pain. And CT volumetry with 3D reconstructions may be the most sensitive and useful diagnostic modality. The reoperation or the need for a revisional surgery is a difficult decision because it's based on the symptoms or the size of the hiatal defect or the condition of the patient. This is an algorithm that we had proposed a while ago, and you can see it is designed for severe GERD after sleeve gastrectomy, and when the patient has a significant hiatal hernia, a Roux-en-Y gastric bypass is usually advised. But this is not the only way to handle this. Which are the risk factors for developing intrathoracic sleeve migration? Hiatal dissection or previous hiatal hernia repair seems to be highly associated with the risk of developing intrathoracic migration. Central obesity, as I said before, is a mild risk factor. Previous abdominoplasty seems to be also a factor, and any other condition that is associated to high intra-abdominal pressures can contribute to sleep migration. So are there any maneuvers that we can do for preventing sleep migration in those high-risk patients? The answer probably is yes, but it's difficult to address or to establish how useful are these maneuvers. This is a publication from a surgeon from Colombia, Dr. Nassar, and he proposed a modified heel procedure for GERD patients after a sleeve gastrectomy. But actually, this is a surgical maneuver that can be done for preventing the migration. And after repairing the hiatal hernia, some stitches using non-absorbable suture are placed from the esophageal gastric junction to the crura in a shape that was originally described by Dr. Hill. And this works as a cardioesophageal fixation, as a cardioesophageal pexy, and in some patients can prevent the migration of the GI junction. Other options are to fix the sleeve to some fixed structures. In this video, you will see something we are doing in some cases with a high risk of sleep migration, where we are pexing the stomach to the pancreas capsule. Some of the authors have advocated the fixation of the sleeve to the mesocolon or some other structures. As you can see, we are placing non-absorbable sutures between the cerebromuscular layer of the sleeve to the pancreas capsule. Some others have proposed the aumentopexy maneuver. Some groups do this in a routinely, because as you can see here, the staple line is sutured to the omentum. We are not very confident that the omentum will prevent the sleep migration, but this maneuver has been proposed as a potential resource to prevent migration. So in summary, we have acute migrations that almost in every case need a surgical procedure, and the chronic migrations. We are proposing a classification of the different types of chronic migrations. In fact, we disagree with Luciano in terms of the probability of paraesophageal or type 3, as we call types of migration. I'm going to show you a couple of images of this type. This is the type 1. You have a sliding hernia with a sliding of less than 1/3 of the staple line, or less than 1/3 of the sleeve to the mediastinum. Okay, this is also a type 1. As you can see here, you can follow the staple line. In this case, you can also see some twisting, and there is less than 1/3 of the staple line migrated to the thorax. This is a type 1 or a sliding type of sleeve migration. Also, this is a type 1. You have the small structure you see here in the upper portion of the sleeves is actually the hiatus, and in the coronal sections you can see that less than 1/3 of the sleeve is migrated to the mediastinum. This is a type 2. In these cases, more than 1/3 of the sleeve is migrated to the thorax, as you can see here. It's also a sliding type, but the extent of the migration is greater than in the type 1. Okay, and as I said before, there are some cases of paraesophageal migration, as you can see here. In fact, the gastroesophageal junction in this patient is almost at the level of the hiatus. And what had been migrated to the thorax is actually the body of the sleeve, as you can see here. And if you superpose this to the coronal image, you can see that almost the whole stent of the sleeve is in the thorax. So this is a type 3. But as in other types of hiatal hernias, other structures can migrate to the thorax also, and we consider that as type 4 migrations or complex. In asymptomatic patients with a small sliding or migration of the sleeve, perhaps a conservative approach can be done. Those patients has been it is important to surveil those patients, to follow them very closely, but not every patient with a small migration, a small sliding of the sleeve to the thorax needs a surgical revision. But what about the other types? The type 2 sliding hernia with over the third of the sleeve migrated to the thorax needs some kind of revision because there is a strong association of this with other complications or GERD. There is a possibility to close the hiatus and just fix the sleeve. But if there is a severe GERD, the performance of a Roux-en-Y gastric bypass is advised, which is also the revisional type that we advise to type 3 or for complex hiatal hernias after a sleeve gastrectomy. As you probably all know, and we have shown before, most of the patients with the sleeve migrations and severe GERD undergo Roux-en-Y gastric bypass. And one of the things that we were talking before the meeting is that using a fluorescence for assessing the vitality of the tissue and trying to guarantee that the tissues are adequately perfused is to use fluorescent angiography. As you can see here, there's a clear difference of the fluorescence in the pouch, in the gastric pouch, to this portion of the distal stomach that doesn't show the well established fluorescence, and this portion of the distal stomach has to be resected. But the bad news is that nothing is perfect, and migrations also occur after Roux-en-Y gastric bypasses, and migrations also occur after one anastomosis gastric bypasses. So there is no silver bullet for this, but the relevance or the importance of a migrated, partially migrated pouch after Roux-en-Y gastric bypass is totally different than the relevance or the importance of a sleeve migrated in terms of GERD and in terms of the dysphagia. It's totally different. So this is just to be aware that in fact, after repairing the hiatus, after converting the patient to a Roux-en-Y gastric bypass, it doesn't guarantee that the patient will not have a recurrent hiatal hernia. But the difference is what is the impact in terms of complications or symptoms that this will have in the future. So in summary, we have two types of sliding of migrations: acute, that obviously need an urgent revision; the chronic migrations that can be managed conservatively if the patient has no symptoms and the sliding is less than 1/3 of the sleeve. But every patient with the severe GERD and migration greater than 1/3 of the sleeve to the mediastinum has to be revised. and probably the most advisable operation is to repair the hiatal hernia and to perform a Roux-en-Y gastric bypass. Thank you very much.
Thank
Thank you very
Andres.
much, Andres. Amazing talk, as always. Edgardo, do you want to continue with the panelists?
Yes, of course. We have 3 amazing panelists. I can see to Patrick and Marcelo. Both of them have a lot of experience in sleeve gastrectomy. I have a question for Patrick and Marcelo. Do you have some maneuver to prevent the migration?
So, yes, thank you first for your kind invitation for this IFSO LAC chapter with this webinar. I think now that I'm becoming a little bit South American guy, and I'm very happy of that. But you know, before I was living in French Guiana, so I have a part of mine as South American. So no, I have not definitely a secret to prevent migration of sleeve. I think they are underreported, that you told. Diagnosis of hiatus hernia is not always sure when you are going to a sleeve. And now more and more I'm checking the hiatus during my sleeve, even if officially there is no hiatus hernia. And in that case, sometimes I'm finding a small hiatus hernia that I'm trying to fix all the time by hiatoplasty. This is the first thing. Then doing a heel maneuver, doing something else, I have no experience about that. I'm not sure it's very effective. As Hanssen proposed to do an odontopexy systematically during the sleeve, I'm not sure it was working. Doing some sutures between the gastric tube and the pancreas, I don't want to try. So I have no secret to do a perfect sleeve without hiatus migration, sleeve migration. Marcelo.
Hello, guys. First of all, thank you very much to be among you. I think we're all good friends here and have been discussing a lot of different topics for a long time. And I totally agree with my friend Patrick that I would not use any kind of fixation to the pancreas. I generally do not use odontopexy. And I think what we have to discuss and have to think is when the patient has already an hiatal hernia, should we go for a sleeve? I really don't think so, depending on the size of the hernia, we can repair it, but this is the kind of patient I would think strongly about doing directly a bypass. So this is one thing. The other thing that I would like to put for the presenters, and first of all, amazing presentations. I think have talked about everything regarding this topic, and it left very few things to be discussed here. But another thing that I think it's important is when do you use, for example, a mesh to prevent these patients to recur? And of course, the kind of mesh would be probably a absorbable mesh. But is there a role, in your opinion, of using meshes to prevent it? That's my first position in that statement there.
Luciano.
Luciano.
Andres?
Yes. Regarding the use of mesh, I intentionally did not include that in the presentation because it's very, very controversial. In fact, absorbable meshes, as you all know, synthetic meshes are related to less or lesser recurrence rates but the potential complications related to non-absorbable meshes is a big concern. I'm not pretty sure that absorbable meshes would solve the problem. There are several reports that the recurrence rate, the radiological recurrence rate after repairs is pretty high with or without meshes. So I do agree that we are thinking strongly about the indication of performing a sleeve gastrectomy in a patient with big hiatal hernias. And there is some, I think that we have not the answer yet, but perhaps the advice will be try to fix the hernia and try some other kind of procedure, because as we all know, the tubulization of the stomach, the hiatal dissection, the resection of the fundus are factors that can be related to the development of hiatal hernia. In terms of fixation, we are aware that some of the maneuvers I recently showed are scary, mainly the fixation to the pancreas capsule. I have to confess that we have been doing this for a long time, mainly for trying to prevent twisting in some sleeves. We perform routinely an hydrodynamic test after we completed the sleeve gastrectomy, and in those patients, in those we see a tendency to rotate to the right. We fixate the gastric tube to the pancreas capsule, and in over 700 patients we have had just one pancreatic fistula, and in that patient we're not completely convinced that that was actually related to the fixation, because the dissection over the pancreas and close to the short vessel was very difficult. But I do agree that there is no a silver bullet to do this. But what I try to encourage is to do something in those high-risk patients. Okay, in those patients with a pre-existent hiatal hernia that required to be repaired, with the central obesity or some other factors that can contribute to the sleeve migration.
Luciano?
Yes, I think it's a really a great question, and I will always remember, I mean, how things change with time and how opinions change with time despite the data. First, what do we do? Primary repair, I will never put a mesh there. I will do just primary repair without a mesh. If there's a recurrence, I will consider putting a mesh. And this is, I mean, with the sleeve or without a sleeve. The interesting thing about meshes is that we've placed, of course, several types of meshes, and the mesh that we've placed the most has been the reabsorbable meshes, such as some of the intestinal mucosal, like Surgisis. And the recurrence of hernia or reflux symptoms in the GERD population, not in the bariatric patient, has been, for us at least, better than what has been reported in the literature. And this is something very interesting, because despite, I mean, this famous paper about a mesh repair of the hiatus with absorbable suture that initially showed that up to 2 or 3 years, the results were just fantastic and great. And Dr. Oschlager actually followed up their patients and had a high recurrence after 5 years. If you nowadays ask him, and during the last couple of meetings, he will say, I'm going to still again place the mesh, because it's going to prevent the recurrence at least for 3 to 5 years. After that, hernias will probably recur. In talking about, and that's just in doing Nissens or fundoplications type of surgeries. In talking about hiatal hernias with sleeve, the problem again is the high pressure of the sleeve. We are not really too optimistic in terms of what is going to happen after repair with mesh or without a mesh in a patient with a sleeve. Physiologically speaking, this high pressure on the sleeve will make this sleeve to migrate again. Probably it's just a matter of time. So we are really not sure if the mesh will help us in the long run. what we can think and be optimistic is that it might help us the recurrence maybe in the short term, but we're still not using it routinely. We're looking more into doing a gastric bypass in that type of patients and not doing it in whenever there's a hernia. So interesting enough, I mean, how perspectives are changing regarding that. I think Dr. Hanssen has a comment.
Yeah, the other thing is that several of this kind of patients will need a revision in the future. And if you already place a mesh and you have to repair, you have a recurrence, and you have to convert the patient into a gastric bypass, it's going to be a nightmare. Okay, it's going to be a highly demanding operation, a high-risk operation, and that's another factor to consider.
There are some questions. I'm sorry.
Go ahead,
Please,
Patrick.
please, Patrick.
Just one comment. I don't know if David has arrived, but possibly there is another option, is to do a end sleeve in some cases. What do you think about?
Just let me add one comment. Okay, your advice would be, at least at the discussion, maybe to think about doing an instant sleeve. And I would add one thing more. Don't you think, and for all of you guys, that using the body clip would be also an answer for this kind of situation? Because we're not talking about a new problem. We're talking about a new concern. This problem was always there, but this is a new concern. So it seems to me that it makes a stronger belief that body clip would also at least it would prevent maybe a migration, or at least an important migration. So this is another topic to be discussed, in my opinion.
I strongly believe that the body clip will never replace a sleeve gastrectomy. Okay, it's a different. Okay, it works in the same way, but as you probably know, the results in terms of excess weight loss are inferior to the classical sleeve gastrectomy in one aspect, and in the other, there is potential for other type of complications eventually. I know everybody says that the slippage is not high, that the erosions are not there, but actually, what we have seen with this kind of foreign bodies is that it will happen. In less or more extent, those complications will happen. So, sleeve gastrectomy is the most frequently performed bariatric operation today. What we really need to do is to do a good sleeve gastrectomy and try to address the problems and to indicate the sleeve gastrectomy in the patient that is a good candidate for that. But I don't think that performing body clips for every patient or for every patient who has a hiatal hernia is an answer.
I completely agree with you. Definitely it's an answer, but I think that Marcelo was not speaking like that. It's an option. With low BMI, when you have a small hiatus hernia, definitely, even if we need more data with long-term run, we have now some data showing that the rate of GERD de novo with a bari clip is 1 to 2%, which is much less than with a sleeve. We know with a sleeve, depending on the series, is between 15 and 30, 40%. So this is one thing. And because of the bari clip is no more a high pressure system, it's a low pressure system. And when you study the bari clip with upper GI series, you see the contrast going to almost to the pylorus, and then in some patient, you have an opacification of the excluded part of the stomach. So it's really interesting for that. Definitely, we can see some slippage. We got with time and with the new technique we are validating, we see less and less slippage, but there is still some slippage, and mostly during the learning curve. Regarding the rate of erosion, we did now almost 1,300 bari clip worldwide, official rate. So we have discovered 4 erosion, but probably it's underestimated because with some patients there are no symptoms, but we will see some erosion, but we think that much less as well than with the gastric band because it's a restrictive procedure and not an obstructive procedure like with the band. So it's a possibility for some patients, definitely low BMI, to do a bari clip. Other option I introduce, the idea is sometimes to do when the patient, they don't want any one-way gastric bypass, is to go to end sleeve. But I don't know if David has arrived or not.
No, not yet. We're not going to defend him because he's not here. But I just want to add one thing, Andres. It's not that for everybody for sure, of course, but it's talking about prevention. I don't think that adding a Hanssen sleeve would prevent the migration. It doesn't seem to me there is a rationale behind it, but of course, putting a body clip could be a prevention for the migration. That's the point that we can discuss. It's something that you're adding to the portfolio of body clip because you're going to leave all the stomach over there and you're also putting a prosthesis that would for sure somehow could prevent the migration. That's the point to be discussed. Not that we're not going to offer for everybody a body clip instead of a sleeve gastrectomy. It's just not the case. But once we're discussing about sleeve gastrectomies and its problems, we are looking for solutions for its problems. And I think that probably will be a place for this kind of another techniques that try to solve specific problems of sleeve gastrectomy. This is my point. This is my rationale.
So great.
If I could add something, I think this great discussion in Marcelo is indirectly pointing out what's the best way, probably the only way to prevent sleeve migration is not doing a sleeve pretty much, right?
Yes.
I'm not trying to be funny, but this is how I think the future looks like. I mean, the chances of having a migration are so high and so sometimes so unpredictable. And especially because we really don't understand that the G junction is a dynamic area that will always be moving up and down with the diaphragm. That's why sometimes even these sutures or the heel pexis don't even work. And even in, for example, I personally consider that the Hanssen sleeve might have some options in terms of preventing maybe fixating the fundus to the diaphragm, but still the G junction might still go up and the patient might still develop reflux with time. So it's a very difficult problem to solve. And again, patient selection is always going to be the key in the long term and follow up. And we'll figure out, I think, in a couple of years, what's the best thing to do with our patients.
Speaking about the Hanssen sleeve, as you probably know, the complications of a Hanssen is the intrathoracic Hanssen, the tied Hanssen, or the sleeve Hanssen. And what will prevent sleeve Hanssen to migrate? Probably the rates will be different, but the risk is still there. We have seen that before in the full applications done because of reflux without bariatric surgery.
Agree with that. I agree with that. I think the recurrence of hiatal hernia after just Hanssen and hiatal hernia repair is 1 to 7% maybe. So it's still a little bit better than intrathoracic migration, but again, very important points.
But as you said, it's a big problem with all surgery. We see now reflux after one-way gastric bypass, migration of some small pouch, even with one-way or OAGB. So it's a problem with all surgeries. There is no perfect surgery.
Now, of course, technical aspects are very important. We have been studying reflux after one-way gastric bypass. And there are several factors associated to that. A big gastric pouch is one of them. Gastrogastric fistulas is another one. A very short alimentary limb is other factor associated with that, and probably with non-acid reflux that is only confirmed with the impedance studies. But there are several factors that are strongly associated with reflux after Roux-en-Y gastric bypass. If you take a closer look on those patients that have reflux after Roux-en-Y gastric bypass, you will perhaps find some factor that can be related with that.
Patrick?
Yeah, no, difficult topic. Interesting topic. No, well, another way to understand that it's really difficult, the problem of reflux. Even in the French government, we check all the patient 10 years after bariatric surgery, whatever the surgery, sleeve, bypass, and the last gastric band, and almost 40% of all patients were under PPI. And in the bypass population, I think it was around 25 to 30% of patients after 10 years under PPI. So difficult.
I have a question regarding a preoperative evaluation of these patients, because I mean the case that I presented in terms of patients don't want to undergo manometries, patients don't want to undergo a lot of studies, patients don't want to pay more. Here at least in Peru is all out of pocket. So I mean, how do you manage this in terms of preparing the patient, counseling the patient when they have as at least the suspicious of reflux, not even hiatal hernia, like the patient that I presented? The patient did not have hiatal hernia, did not have GERD symptoms, had a very mild GERD on upper GI when the patient was placed in supine position, but the patient wanted to proceed with sleeve, and even told me, even if I go manometry and the results, I don't care about the results, I want a sleeve. So again, no esophagitis before surgery. I mean, what tests do you guys do before? How do you counsel the patients regarding this problem?
So in my practice when I was daily in France, for all candidates to bariatric surgery, all candidates without symptoms, we have to do one upper endoscopy. 100% of the candidates for bariatric surgery have an endoscopy. And when you have severe esophagitis, when you have symptoms in some center, but not all center, they are doing some manometry or to complete the assessment. In Dubai, in the Emirates, it's completely different. Patients are paying their surgery, and for the majority of them, it's really difficult to attend, even if they are Emiratis, to pay one endoscopy and other exams. So I'm trying, when I have a patient without any symptom, young patient like girl, 20, 25 years old, no symptoms, I don't do any upper endoscopy. But when they have any symptoms, I'm doing, and when we are finding esophagitis lesion or other, I'm going to bypass mostly.
Yeah, I think we have a very, very close reality. We live in very close environments here in South America. So of course, the most part of the patients, they don't have extra money to pay for, exams. So I share the same problem, Luciano, as you have. So I really like the upper GI series with the contrast X-ray, simple X-ray study, that we add a lot of information together with the endoscopy. So I think this is a good solution when you don't have, other ways to study these patients because it's too expensive or because the insurance doesn't want to pay for it. So that will add a lot of information for us, especially if you are with the patient in the radiology room. So this will add a lot of information. This is something that we can do. It's not the the ideal situation, but it works pretty well, I think, in general.
No.
There are some questions for the audience. I will do the question, and Please, Patrick, Marcelo, Andres, and Luciano say yes or no. Sergey Elias asked about your opinion about the routine hiatal dissection versus non-touch the hiatus in the sleeve gastrectomy when you have or you found some little hernia, or you don't identify hernia in the intraoperative technique. Do you have a routine dissection or not?
We're becoming less aggressive in hiatal dissection because we feel that an aggressive hiatal dissection will promote migrations. Okay, if you have a really relevant hiatal hernia, you will see that mainly in the upper portion of the crura and when you reach the left crus. I think that routinely dissecting aggressively has to be avoided to prevent migrations.
Luciano?
I think that's a great question. We preoperatively do upper endoscopy and upper GI contrast study. So if one of those, at least, and we try to get some physiologic studies such as pH, impedance, and manometry. If in any of those studies, there is a suspicious of hiatal hernia, we're gonna go explore it even if we don't see it during surgery. So for some reason, sometimes the hernias might be not, evident. So we're gonna do this dissection, and most of the time, if not every single time, we're gonna find something, at least a small area of the fundus. We always, in every single surgery as well, we're gonna expose the left cross, so just like it is recommended. But if there's no hiatal hernia and no suspicion, no symptoms, no nothing, we're not gonna touch that area or explore it. No routine exploration. I agree with that.
Marcelo?
I like to be in the middle, in the way of the middle. I think we surgeons, in my opinion, should think like that. So just following more or less what Andres said, if you have a suspicion, a high suspicion, to go and try to fix it without managing, dissecting too much. And if it's a small thing, you don't think there's an hernia, I would prefer not to touch it, for sure.
Patrick?
I have exactly the same opinion than Marcelo. Exactly the same. No symptoms, I don't go. Small hiatus hernia, I try to do the minimum. Not to do an extensive dissection, like definitely like the other guys. I think if we are doing an extensive dissection, there's a higher risk to possibly to have a migration in the future.
Perfect. Lucho and Mariano, do you have some question or opinion?
I think no, Lucho.
Yeah, thank you. Yes, my idea, my opinion is the problem. We have a zone that it is completely in constantly movement. That is, if you pass, the esophagus goes up and down and goes completely dilated and concentrated. If you don't know the physiology of this place, it is very difficult to fix any kind of problem that you can find there. The fact is that when you have some suspicion of short esophagus, that I don't believe in short esophagus, because I think that this is not well desiccated, the esophagus, for me. But if you arrive to have a very good in working in gastroesophageal reflux disease, we have a very large experience about that, and we saw migration after fix the crura and resolve the big hernias, median hernias, or little hernias, and we have some kind of migration. I mean, 6%, 1%, but it's between these two numbers. So I think that our conception is to fix the hernia if you find, and if you have the hernia with any of the study that we have, and fix the hernia, but it's not always the same to fix a huge hernia and to fix a little hernia or a little slide of the fundus. So for me, this is the difference. If you need to make a huge dissection, at the end, the possibility of a sleeve, it can be done. So it's very difficult to answer this question, but for us, we perform the same to fix the hernia, and we are always looking for some kind of migration to make pursue or change our idea. But till moment, we think that we need to fix the hernia. Then when we found the hernia, we fixed the hernia.
Okay.
I would like to make a small comment regarding Luciano's question regarding the pre-op studies. I think the endoscopy is mandatory. If the patient don't have money for paying the endoscopy, I don't know, but undergoing a bariatric surgery with no endoscopy, in my opinion, is very, very dangerous. Of course, perhaps we cannot do for all the patients manometry, pH, impedantiometry, and all that stuff. But I think endoscopy is mandatory for the 100% of the patients that are going to go in the OR for a bariatric surgery.
I think we all agree with that.
I have a question. I am gonna make a question that all the speakers, panelists, and all my people in the communication group. So if you have all the possibilities, I mean, endoscopy, fluoroscopy, pH, manometry, and impedance for free, do you perform that workup in all the patients? What do you think about that for free?
It's a hard question to answer because the intention to treat rate will be very low. Okay, actually the findings, beside endoscopy, I agree that we perform endoscopy routinely, and we are very, very aggressive in trying to assess symptoms. But doing routinely impedantiometry, manometry to every bariatric patient that will undergo a sleeve gastrectomy, I think it's not necessary, and the number of pathologic findings will be low in terms of changing to your approach to that patient. So the waste of resources will be very high because again, the intention to treat rates will be very low.
Yeah, but what about with sclerodermia? What about with achalasia? What about with tumors? What about this severe dysmotility? I think that you need to change your way to think about, to choose your technique, don't you?
Yeah, for sure. But tumors, you will find tumors in the endoscopy. If we were thinking that way, perhaps an endoscopic ultrasound should be performed in every patient. Or I mean, I think we have to establish what is the standard and what is not. If the patient is symptomatic, I agree. I will do functional studies on that patient, because the operation would be completely different, or the decision-making process will be different. But in a routine patient, with who is a young lady without symptoms, with a 34 or 35 BMI, I think an endoscopy is what we usually advise.
Patrick and Marcelo, if you have for free all this study, what do you do?
No, same. I'm between every position. Endoscopy for the majority of patients, definitely. Even for a 20 years old woman, no symptoms, BMI 35, I'm not sure it will help to do an endoscopy. But for all patients over age, definitely endoscopy for sure. Possibly manometry. Because as Lucio said, we can have sometimes some dysmotility symptoms, even if it's not very frequent. You can have some achalasia or part of achalasia. So yeah, if we add for free for some patient, maybe I will add manometry.
Marcelo?
I have reflux, and I would go at least for endoscopy. If I
Go
were
to Montpellier.
Yeah, but I'm not obese, not yet. But so I have a reflux, and I would for sure would go for an endoscopy, and at least an endoscopy and manometry, and maybe if I were the patient and really do everything, because I think when we get sick and when we have a proposal for a functional surgery like that. I think we should be very well studied, and because this is something that will change our life. So if I have all the informations, I would like to know them. But of course, we have a bias because we are doctors and we know how do you feel, and so it's difficult to put myself in the side of the patient. But if you can get the information, the good information, why not? Because that will increase the chance of having a better choice for our patients. And this is my general opinion for the most part of the diseases and the surgeries that I do. When it's available, of course.
If I may add a comment, this is a very, very common question and something that we discuss a lot at our service. I mean, and the answer is we have just way too many questions. We don't understand why this happens so often. So nowadays that we still don't know, I would say yes. If everything were free, I would absolutely perform everything, every single test until I get the answer to know which of these tests is better. Because what we know, at least from the population that we have studied, is that esophageal dysmotility is high in the obese population, 20 up to 40. After sleep, it goes up to 50 or 60. Impedance is really high. A lot of patients are not diagnosed with the Mr. score necessarily because of acid reflux, but they have bile reflux even before the sleep. So, and these patients have been described to have even worse GERD or even Barrett esophagus after sleep. So we don't have an answer. It's impossible to get all the tests done. Nowadays, that these tests are not free. I'm pushing develop to do at least an upper GI in every single one of my patients. And this study brings us a lot of information, but that's not a standard recommendation. We know that even endoscopy recently has been addressed as an important test to be performed. During my fellowship, we did 0 endoscopies. I did several sleep and several bypasses without doing an endoscopy if the patient didn't have symptoms. So I think it would be amazing to have some international collaboration to get all these tests done in a very large group of population to really figure out how do we need to proceed and when not to do a sleep, or when the chances are really bad of a patient getting GERD or a migration, because that question doesn't have an answer yet.
Perfect. Mariano, Lucho, I think we were here 1 hour and 23 minutes. I think we can finish this amazing topic. What do you think?
Perfect, Edgardo.
Okay, thank you. Thank you everyone for coming and joining us in this webinar. We are going to work to prepare the next one, and we are going to choose some topic like this, that it is very controversial, but we need to have this kind of discussion because it's better for us to be thinking and trying to improve our recommendation. So in the name of IPSOLAC chapter, I am going to finish this nice webinar. And thanks to our speakers, Dr. Hanssen, Dr. Poggi, and our commenters, Dr. Patrick Noël and Dr. Loureiro, and always our collaborators, Dr. Edgardo Serra and Mariano Palermo, who are the best of the best. Thank you very much for joining us.
Thank you.
See you.
Bye, guys. Thank you.
Bye-bye.
Bye-bye.
Thank you.
Bye.